Buenos días. Bienvenidas.
Good morning. Welcome to the third session of the International Forum on TB, FoVI-TB 2022. Before we begin, I would like to inform all the panelists and the attendees that this session is being recorded and is streamlined on YouTube, Facebook, and Imagen TV channel by the UBC. We also have a Spanish channel on YouTube, Divulgar ECS, another YouTube channel in English, which is Premi TV.
Can you hear me?
The broadcast streamline of this process is done to the support of the production and the visual support of the UBC, to which we thank for their great support.
Then turn off my camera.
This forum has been done thanks to the support of different institutions. Health Science School through the Internationalization College by the University of Baja California, U.S.-Mexico Health Border Commission, and then Multidisciplinary Network of TB Research, TB, National Center for Preventive Programs, and this is controlled SENAPRESE by the Ministry of Health in Mexico, and the National Research Network for Prevention and Control of TB in Mexico. Is Virtual International Forum on TB has a purpose to generate an open channel for biomedical and scientific communication regarding prevention, diagnosis, and treatment of TB in order to reach the goal of the end of TB set by the WHO. This strategy tries to reduce 90% the number of deaths from TB and 80% the incidence rate of TB by 2030. Regarding the reference values of 2015. TB is still one of the most lethal infectious diseases around the world. Every day, over 4,000 people die a day from TB. It's important to remember that TB can be healed if it's detected on time and treatment is completed. Likewise, we remind you to those who are here with us that we'll issue diplomas, attendance certifications. Please fill out the forms on the REMITV website. And also, for those who haven't logged in, you can go to the website and you will find the registration form, or you can also use the QR code. It will be on screen throughout the presentations. I'm going to introduce Dr. Lourdes Canera Ajienagua, who is a research investigator in the UBC and the Social Administration School. She will be the moderator for today's session. Thank you, Doctor. Thank you, Doctor, for your introduction. Now I'm gonna introduce Dr. Héctor Javier Sánchez Pérez, who is a researcher at the Colegio La Frontera Sur, ECOSUR Chiapas, and he also works for the TB Social Observatory in Mexico. Dr. Sánchez Pérez, he's a researcher by the Ministry of Health in the Colegio La Frontera Sur in San Cristóbal de las Casas, Chiapas, in Mexico. He's a technical secretarian of the National Observatory of TB in Mexico, coordinator of the ECOSUR group, which are research groups for America and Latin America. He is a director of the TV show Mirada Crítica. He's a host for that show. He's also a member of International Amnesty Mexican section. He's also a member of the research group in Mexico, the health department. He's a medical doctor, and his specialties by the University of Barcelona. He has a science and public health master's by the University of Barcelona.
But we don't want to have a fire again. We already put out the fire, but we don't want to prevent it from happening again.
He's also co-written several publications and international magazines, and also, as well as is collaborating in the creation of several books. He has provided training at the technical and community levels
we're working on developing
Oh,
new
he
vaccines
has
that
also
are more
been
effective.
working different diploma courses for different for healthcare providers.
Secondary strategies are fairly have been we have a
The
lot of
conference, the
success
talk he
here. We
will
have
be
to
giving us
avoid the
today
disease
is titled
embedded disease
TB
happen
in Mexican native populations.
infect people. We
Doctor,
have the
I
PPG or
remind you that you will
TPG,
have between 40 to 45 minutes for your
we have
presentation,
some
and then we'll have at the end some time for a Q&A session.
for 3 or 4 months time. They're still effective as longer schedules that we
We'll
have
be
in the
answering
past.
all
We
the
have
questions
they
asked by
have
our
some
audience.
easiness
So we
in.
want to thank the doctor for his
Third strategy is to
participation.
avoid
Thank you so much.
side effects or
Take it away,
any
please.
consequences.
Yeah, hi, Dr. Lourdes. Thank you for your invitation. I'm honored to be here with you. I'm going to share my screen right now.
Focus on risk populations.
Can you see my screen? Can you see my screen now?
Those who
Could anybody tell me? No, not yet. No, there you go. Now we got it.
are a high risk of having probably
Well, once again, thank you so much for the invitation
people living in prisons,
for this international virtual forum on TB.
indigenous people,
As you said, TB is highly related to poverty and vulnerability factors in the different populations. It's particularly to those. There are some other comorbidities such as diabetes, HIV, and addictions such as alcoholism, tabacism, and among others. Although all they have a related to TB, and they may have an impact on the population depending on the population we're talking about. We know in working age, there's more incidence, but there's more mortality in the elderly. And we could also see that this disease knows no borders. It crosses borders and everyone can get infected. So we're going to talk here today about I'm going to talk about native populations. I'm not gonna call them indigenous people because we are all indigenous in a way. So I would rather use the right term for this. I think the right term would be native populations. So because native populations, we talk about those social groups and cultural groups that share bonds with the land and the resources where they live. And some of them have been moved from the original land. So we know that's happened. We know the land where they live in and the natural resources they depend on. They are definitely linked to their culture and their living. And also, they don't talk about health. They talk about well-being. That's the term they prefer. You know, many of these populations have lost their native languages because dialects, we don't call them dialects. I think they are all languages. And all these languages are about to be extinct due to all the discrimination they have been subject to. There are some reports that are about between, there used to be about 30,000 or 3,000 and 7,000 languages in Mexico. They have been lost, and many of them have been lost. And we expect that the same way we're killing off animals and plants, we're also killing off original languages that by year 20, right, by year 2100, we're going to have very few left. As I said, we are going to be talking about indigenous people that represent 6% of the world's population, but they're overrepresented, those who live in extreme poverty conditions. These type of populations, and they even live, the lifespan is 20 years shorter than the rest of the population. We know that usually they're the last to get investment, basic services and infrastructure. And we also know that they face different obstacles to participate fully in formal economy. And they are denied access to justice. And also they have problems, or they cannot participate in decision-making processes and in political processes. So we know that all this makes them more vulnerable to the different conditions such as global warming, diseases such as TB and COVID-TB, most of the infectious diseases. So, and this also has to do with the lack of access to the national healthcare system and to water and sanitation in general. In the case of our country, currently we have 68%, 68 native populations. So before the Spanish arrived in the territory, there used to be over 500 towns, peoples, and now we only have 68 left. As you can see, some of the populations, they may mention only 62. The fact is that we're between 62, 68 populations and about 364 language variants. 6% of the population live in these native populations, according to the latest census.
0.5% or more.
And this tells us that 7.37 millions of indigenous or native people live here. And so we can say in these households, about 11.8 million live in these in native households, and the most spoken languages are Nahuatl and Maya. And we should also remember that we have people from came from Africa, and we have 7.2% of the Mexican population came from Africa originally, and 7.4% of those 2% speak indigenous language. And we don't have enough information because of COVID. We could not collect all the data regarding these peoples. So the National Institute for Indigenous Languages shares information with us. The latest information from 2015 tells that about 25 million inhabitants in our country see themselves as indigenous. About 25% out of those 25 millions, a third, they speak any of the 68 languages. They live in at least over 43,000 sites.
People living with HIV, right away we need to do a chest X-ray.
And the most of the populations that have this kind of populations is Veracruz, Oaxaca, Chiapas, Estado de Mexico, Puebla, Yucatán, Guerrero, and Hidalgo. And this is state that conform about 75% of the total indigenous populations.
Cough, fever, weight loss.
So I said that we had 4,000 native languages. The UN would say about 40% of those languages were at risk of being extinct.
And then for their checkups, and we identified
in 2010, the census recorded almost 7 million of people speaking those languages. In 2020, we had a larger number of population in the states with more indigenous speaking languages speakers. You can see them on the screen. And I said we have Nahuatl, Maya, Tzeltal, Tzotzil. Those are very similar languages. Also have Mixteco, Zapoteco, and Otomí. So this is Afro-descendant population that I think it's a very important. We need to learn about this population.
These are all active.
So we know that in Mexico, the people before living here before the Spaniards came, they will live.
For instance, if we have symptoms, respiratory symptoms, and
those people still live here, and they live in the outskirts of the cities, and they don't have access to public health system. They have less access to education, and this indicator definitely is. We see this as a socioeconomic indicator because we know that many of the municipalities where these people live, they have very low development index. Also, women. We need to see how women live here because in these native populations, they have very bad living conditions. In case of women, it's even worse. So out of the 25 people living in native populations, almost half of them are women, almost 12 million are women. I said that 32%, approximately 32% speak a native language, and they are more discriminated against by gender, the ethnic groups, and social class. And whether immigrants are even more discriminated against. We know that they suffer structural violence and generate several barriers for their own development and well-being. They have more illiteracy rates than compared against men. We know that they suffer from family violence, domestic violence, and they have less access to justice, and there are not enough public policies to solve this particular problem for women, indigenous women. We said since in recent years, there was an event that brought women together in Mexico City. They would talk about the discrepancies between women and in urban women and women who live in rural areas and from indigenous groups. We know that these women, they have higher pregnancy death rates. In 2019, about the number of kids they had, it was 2.8 kids per woman. And we know the living conditions, obviously, they keep them from having good eating habits and eating healthy food. They have to work very hard, and obviously all these lead them to develop more diseases or get infected by some conditions. So we have, and this data is from Colombia, Barranquilla. They also use the coca plant with the coca leaves, and they're only for the use of men, but they collect these leaves, and they would say, okay, that's they play such an important role. And as this, we see when we talk about TB, we know that in Mexico, in the north part of the country, we've been talking about molecular diagnostic methods, but in the corporate portion of our countries, we talk about using microscope for bacilloscopies, which is the most popular diagnostic method in Mexico. And we know that we are being left behind by the recommendations from the WHO. We know there are many studies that have been done about the large or the exacerbated amount of TB in these native populations, but we need to work more because we don't know the actual TB status in these populations. We know that without the early diagnosis, the transmission cycle continues in these communities. The people do not complete treatments, and obviously they have higher death rates from TB. So that's why I'm here. I'm very, very pleased to be here because we need to prioritize TB control in these populations. We need to have better surveillance of the TB burden, and we need to work on the treatment in these populations. The following slides I'm going to be showing you shortly, coming from a document that you can find on the internet. It was published in 2021. It says guidelines for controlling and diagnosing, controlling, and eradicating TB in indigenous populations. And see, here we have data from 2012 and 2016. Even though it's a recent publication, we have some somewhat old data, but it shows the current situation in Mexico against other countries. In Mexico, we have by far the largest number of TBs for TB. If you compare against Brazil, we can see on the left, we can see Mexico and Brazil. We have more cases than Colombia. And this table, you can see the second to last column, we see TB incidence in native populations and incidence in total populations. We see in Paraguay, we see have an incidence of in the countries 36.3 out of 100 inhabitants. In the case, in the indigenous populations, we see how this number goes all the way up to 335 people out of every 100,000 inhabitants. In the case of Mexico, we have lowest incidence rates in native populations and compared to the rest of the population. We have to wonder if that's the case or if we are not measuring properly in native populations. In this graph, these are the two columns I was telling you about. You can see the burden in the different countries. We have Venezuela, Colombia, and the orange. In orange, you see higher rates in indigenous populations, but in Mexico, curiously enough, we don't have those numbers. And I say this curiously because we are not sure if this data is accurate. We may not have the right data for this.
28,000 X-rays, digital X-rays, 88%.
These graphs, the graphs I'm going to show you now, they were shared by the National TB Network by Fatima Luna, who is the director for this program. And in the case of Mexico for 2020, we're talking about the pandemic times. Indigenous people, they had just 7.5% of the TB cases were in these populations. So if we compare 2021, we see that the number in native populations, it drops a little.
And out of those, 79% received treatment in our.
We had a drop in these numbers in 2021.
For different reasons I will explain to you right now. So important is we have an incidence rate of.
As you can see, the number for indigenous populations dropped from 7.5 to 6.2. Well, we also see on the left, you can see the number of deaths in indigenous populations, so native populations in our country. In 2019, we had 220 deaths. Oaxaca was second with 37. On the right, you can see the incidence in native populations. Chiapas, 195 in 47 municipalities, Oaxaca 186. And here you can see the numbers, the deaths reported by TB.
We will have an X-ray evaluation, a clinical evaluation.
The graph I show you for 2020. About the next slide I'm going to show you will be for 2021. I said 220. Well, when 183, that's from TB. Once again, I don't think it's because we had less deaths from TB. The thing is that maybe there were some other factors that actually had an impact on the collection of this data. And we also have the incidence. I use these arrows for the states with the highest population, native population.
Had to do a lot with interventions. We had to intervene with
and we see they represent about 10% of the total municipalities in the country. This is the incidence divided by state. And we see that for 2020, we have them in red, the average, the national average. And on the right, we see the regions with the highest population of native populations. On the next slide, we see for 2021, we have the same trend with more current data. Because using the TB national network from the TB national program. And we need to work more on this in native populations to learn more from them and what the actual situation is. On this slide, I think it's important to take a moment. We can see the diagnosis with molecular methods. In some publications, they said consistently, they say that we should align ourselves to new technologies and better diagnostic technologies. because we talk about rifampicin resistance in some of them. And so if I remember correctly, in some of scientific populations, that the average in Latin America for cases that were diagnosed with molecular methods are over 90%. In the case of Mexico, the state that is in the poorest condition is Tlaxcala, which is a very small state, it's 23%, but the rest, we are not doing very well. We see the case of states where they have large numbers of native people living there. We see how the most of their TB cases are diagnosed through molecular methods. So I think it's very important to highlight this. TB mortality divided by states. Historically, we have Baja California and Sonora, and then we need to see what the burden is for the people moving from the south to the north, and also states of Oaxaca, Guerrero, Yucatan, and Hidalgo, where they live, how this may vary, how this data collection may vary. If I remember correctly, when we started talking about TB here in Chiapas, back in 1994, mortality, the state has always been high up in the numbers, but incidents we are in the third or second or third place, even in ninth place. So this changes, it's always changing. This is a graph for 2020. You see Chiapas is high up for mortality rates, but if we see this for incidence rates, we see it's very low, very unexpectedly low. And it's important to mention that sometimes we have problems diagnosing TB, community TBs, particularly in those who are not pulmonary TB, for instance. All different kinds of tuberculosis are even more complicated for us to diagnose because we didn't have enough vaccines in Mexico to protect our children. And also, remember the event we had in 2019 when we had that I am a doctor case, in case in Jalisco, where there is a teenager who was not diagnosed with TB, had several interventions. At the end, the person died, and the death was, it was a gastric TB case. So there's another issue or another subject that is at national level it can be a problem. And the indigenous population is even more so due to their conditions. I would like to see that how far they live, but I think the problem is the low infrastructure we have for this population. We have a low contact tracing for this. In the rural communities, it's even more complicated, and the numbers are even worse because very often it's very difficult to reach those places. We don't have enough resources. Different municipalities, maybe we don't have money for gas, or we don't have a driver, we don't have a vehicle, we don't have resources to go and not only to do contact tracing, to give them the right treatment. I don't want to elaborate much on this, but this is a serious situation. And these are the numbers for 2021, 2020, 2021. These are the data we have for Mexico. The preparation of new cases in Mexico, I would like to say I would like to say respectfully that I don't believe this data because we see the Baja Chiapas had 88%, and I believe that we should check this data. I wish this was the case, but I don't believe so. I don't think it is too pretty to be true. So we could say that we could talk about TB in native populations. We don't have very good data, very accurate data, but we have evidence. We have data that might give us an approximate of what's actually happening in terms of numbers and in terms of qualitative factors to be able to explain what's happening in those populations. There are high probabilities of lack of completion of TB, treatment. We know we have lack of infrastructure. We don't have enough medical staff in those areas.
The numbers went down during the pandemic, but generally speaking, the trend is always
We
upward.
have some doctors that are still in medical school, and they don't have all the information necessary to care for these populations. We lack supplies. We have some administration bureaucracy that keeps us from actually achieving our goals. Sometimes the people are mistreated. People are discriminated against when they visit the healthcare centers. In Chiapas, we also have people don't believe in the national health system. Also, the distance, because some people, when they want to go to these communities, they have to walk for even days to reach those places and provide them with the care. So, and also the lack of financial resources. Some families, they have to go all together to the doctor, and they have to pay for everything because they don't have anyone to leave the children with, so they have to bring the children, and it represents a high cost for them. We also need to have gender factors. They play a very important role for diagnosis and treatment. Also, inter and intra communities communities among communities, conflicts among communities. In Chiapas, we know that this is a big problem. And also within the communities, for instance, religion, political party affiliation also may have an impact. And because people don't feel like they're part of a community per se, they just feel like they share the same space, but they are not a community anymore.
Because if we don't address this, most likely we're going to develop drug resistant or drug resistant cases. So
the reasons why we cannot use federal resources for these towns is I think it's very important to see how Prospera disappeared. Those federal programs that were very useful for the people, they just disappeared.
55 to 60%.
And once this program disappeared, they had a great impact on the community's health.
And this is based on treatment in the country. And XDR,
Then
it goes high, it goes up.
We would go to the communities and ask people why you are not using the existing programs and municipalities with high number of native populations, and there are not enough programs. The existing programs are not mandatory, and they rather have private medical services because they don't believe in the programs offered by the government. Also, they tend to use traditional medicine instead. And also the fact that they have to work and they cannot take the time to go visit their clinics. They are remotely located. So what we're trying to convey here is TB can be curable, TB. We can see when tuberculosis was first identified, how we're doing today, and when HIV was first identified, how we're doing in terms of HIV. So we see there is a big discrepancy.
So this is a recent evidence that we have evaluated in research that is being done right now.
And even for COVID-19, that now how the situation has changed in the last couple of years. Now we have better population, with better medications to protect the population, even some vaccines. And this progress has been very fast.
Here we can see that in theory
but I think that I don't want to sound pessimistic, but I think TB will be the #1 infectious disease causing death in Mexico in the near future.
First, you need to isolate the bacteria, and then
I would say that we are experts in treating, but not in curing. And then it becomes a chronic disease and a drug-resistant disease, and that's our problem. And we know that Dr. Isaías will elaborate a little bit more on this.
greatly when those who start with LPA.
And we see that we are failing at healthcare system. Even though there are some biological factors and
drops to 50 days.
in child mortality, we know is a big indicator of the health system.
Helping us diagnose faster.
And also, I think an issue that needs to be discussed is the lack of communication between TB and human rights. TB organizations and human rights, because we know that we have several Mexicos within the same country, different realities.
But the answer is no. We have talked about the comparison.
Because we know in the big cities we have great healthcare system, but indigenous groups, they don't have those. Their facilities are terrible. Sometimes they have their clinics in their own homes.
These are schedules that were done in the last decade. They were injectables for.
So according to researchers here in Chiapas, we see the mortality, the TI is done in very low levels, and there is abandonment of treatment due to unattended side effects. And this applies to the rest of the country. And also the insecurity, the violence in Mexico, this applies to all the country. Yeah, high levels that we see of drug resistance, multi-drug resistance, and primary type, cases that have not been treated, but they were infected with drug-resistant strands. We have had some research about the key indicators to predict higher rates of multi-drug diseases.
Diagnose timely. You need to work more. You need to have better system.
So we see that being a part of the indigenous group, they do better for this. They have less multi-drug resistant TB cases.
2011, they had this treatment.
In these two indicators, we have higher possibilities of dying than the rest of the population. So only a few indicators from the Public Health Department from 2018. We said that we need to focus again on the vulnerability factors for these type of populations. 7 out of 10 indigenous people, they are living in poverty, and it's even worse for women and the elderly. 8.3 million people, 1 out of 3, they live in extreme poverty, and they have at least 3 social needs that have not been fulfilled. So we see that this was pre-COVID. So we see that by then, 70% of the population in Oaxaca are living in poverty, and in Chiapas, 77% of the population lives in poverty. So when talking about extreme poverty, when we compare, we see indigenous urban men, and if we see indigenous people living in the cities and living in their own communities, we see a big change in their conditions. We also talk about the lack of social security in the indigenous groups. Sometimes there are some communities where they basically don't have social security. We used to have the Seguro Popular. Some people hated it, some people supported it, but I think in a way it was not fulfilling all these population's needs, but it definitely protected them in some way. But now they don't even have that unless they go to a private physician. So in summary, to wrap up, yeah, TB does not affect all the top of the population the same way. This is a summary of the impacts they have on the populations. We know this is a sum of all the different unfavorable conditions experienced by these populations.
So we need to introduce experts, and not only that, but we need to find some other
we see that many of the communities, the Human Development Index is very, very low.
To make sure that this
so what can we do? What do we? Yes, obviously, we need to
find some drug resistance. We need to
work together, not individual, but collective participation in trying to change this reality. These social observatories have been operating in 8 countries, and in Mexico, we just had our first social observatories, and we have better communication with the national TV program and with some of the private practices. The academia should also get more involved in this, trying to train better healthcare providers.
So this is very important. People
And here
grasp these concepts that are very important.
we need to have a multidisciplinary approach to TB, considering human rights and gender discrepancies. And as I said, yes, we should also always focus on human rights. These native populations, they also have human rights for TB, for right to prevention, to early diagnosis, to treatment, contact tracing and prophylaxis, and particularly getting an early diagnosis and timely treatment for free. Let's keep in mind that TB generates more socioeconomic impacts, produces more poverty levels. People are incapacitated for work. So if we see that we have more infections, we also know that many of the TB programs are not targeted at children, and that's not right. That's something that needs to be changed. We see people older than 65 and older, well, they need to be addressed because they're more vulnerable. Their mortality rates are 6 times higher than young people. We already talked about women, how they do even worse on TBs and diagnosis and treatment. In the case of children, we know the existence of we talk about the lack of contact tracing, how preventive treatment and therapies are not being successful to keep children from being infected with tuberculosis. And we know that TB can be more lethal for women, for younger children.
Adjusting to the changes in some people would leave treatment.
Now things are even, we need to work harder to reach these vulnerable populations.
Remember that hope doesn't die.
And we should try to have an impact from our end. We know that TB can sometimes has an impact on the socioeconomic sphere, and then let's do what we can on our front. I have a colleague who works in Lambasquez's organization. He told me that once he was, and he had a meeting with the population in early this year, and he was talking to the community leader. And when he asked about TB and the services provided for that, he just left him talking. He just left in the middle of the conversation. He was wondering, what did I do wrong? Then another person said, you know what, they have been promised healthcare systems and healthcare programs, but we have gotten nothing or very little. So I hope that we can start working on this. This is the publication I mentioned earlier. You can find it on the internet. So there are very few articles for this. Once we published an article for TB and human rights, how these groups are being marginalized. This TB population in native peoples, I cannot discuss this, but it provides very good guidelines that I think are very important to be taken into consideration, and I think would have a good impact for people who have the privilege of working in these populations, with these populations. And some also contain some suggestions for public policies, generating evidence, for instance, and based on this evidence, create new public policies and acknowledging the ancestral and traditional medicine knowledge.
Punctual intervention. It's been done
And
in
well,
the last
thank you so much for the invitation once again. And I want
to
to invite you to encourage you to do what you can to change the reality of all these people, because when people say that
the acceptance of the population, the play,
we should all work together,
for a while.
we should have a community will to change this. Thank you. Thank you so much. Thank you, Dr. Sanchez, for your very interesting conference. And now we are going to open this session, this Q&A session. Dr. Sanchez, the first question we have is, with the new perspectives from the federal government in recent years, we have seen a difference in the interventions and access to healthcare in these indigenous populations. No, not so far. As far as I know there is a political will to actually do that, but right now we haven't seen any difference. We hope that now the COVID-19 is not an emergency, we can reallocate the resources to these kind of conditions. Unfortunately, we see the lack of resources in these communities. They're understaffed. We know how they were talking about how could get Cuban doctors to work in Mexico. Said that the reality is many indigenous groups, even though they open to doctors, and they need new medical staff. Some people don't want to go there. They don't want to live in under those conditions. They want to stay in the cities and they don't want to go to those remote locations. But we need to work together, and we need to start changing the way things are being done right now, because we know that unfortunately in some indigenous communities, even the healthcare providers, some of them, not all of them, of course, there are very good exceptions. They want to be changed to urban centers because they don't want to live in those communities. So I think for human rights, the type of the observatories that we have for mother deaths, we need to see what is obstetric violence, how this impacts the female population. So all this population that they have a voice, and in the case of TB, we don't have any. I think we should start working on this, trying to, as the public health, to give better services, healthcare services in those populations. So something that caught my eye is what you mentioned about the allocation of resources. And I don't think that's is addressed. Most of the times we talk about the operation of healthcare services, but no, we should also talk about colleges where new doctors are being educated. Yes, even when people go to do their social service and see some of the induction courses, they are not necessarily about the diseases that will be seen in the community. You just fill out a lot of forms, all the paperwork that has to be done for them to be able to stay there. But I think it looks like the major concern is not addressing the community's needs, health needs, but just do numbers and fill out all the monthly forms. So it's a lot of paperwork, but it's something that needs to be changed. But even though we do need that paperwork, I think providing good healthcare is even more important.
Yeah, it's a very hard question. Yeah, Rafael is going to come next month.
Thank you. We'll continue with the second question,
because we know this is a serious situation for us,
which is, are there national projects for the conservation of these native languages, similar to the conservation programs we have for conservation of audiovisuals?
So they
Yeah.
are Peruvian?
Yes,
Okay,
yes,
okay.
we do
So
have
that's
them,
why
but
you
it's
have
not
until
sufficient.
until
You're very
that's
insufficient.
why. So it's a lot. That's sad.
Yeah, because we can talk about
Protecting the
native
bias
languages, that there are some government and non-governmental agencies that have been trying to protect these languages.
We
But
need
sometimes,
much more than we're getting, and we need to do a lot more than what we're doing. So there are some serial situations.
to translate some text, we need those
The
languages,
situation is
right?
very complex because we don't know if this
So we will need to have more
is gonna
aggressive
be
policy
in office
for
for
protecting these
a month
languages,
or a couple months.
not only
There's a
in
lot
terms
of
that at least in
political
Mexico,
instability.
we should,
In
people
addition to
living
the
in some
pandemic
states
that has been impacting
with these
how our
large
healthcare system.
native populations say, at
we're
least in their own
in a tough
language,
spot right now.
good morning,
What
good
we found
evening.
is that
But we
now
also
there's
need to
restriction.
learn their
We
culture,
receive that, but we know what we need to do.
because sometimes we even just
For
walk
that,
by
we
an
need a lot of
indigenous person on the
resources,
street and
time
we
and
don't even
money.
say hello to
So
them.
we want to use
We
experts
need to
from other
create more
countries.
awareness and
We're going to complement it with
in
some
our
other
population. So we change
tests.
the way things are being done right now.
Expand digital X-rays
Yeah, the
to other
next
countries
question has
and
to
be
do with
able
the
to
previous
have
question.
CAD
So
for the analysis of those
how
X-rays.
do healthcare
So we
providers
know what we need to do, but we
overcome
don't have
language
the
barriers
resources.
in
We
those
need to
communities?
update the strategic plan
Because
and
usually
try to
we use
find
interpreters
source of
from the community
financing
with promoters.
for us and some more allies in the
This obviously
community,
has to
the
be,
civil
this has to be done.
society,
But I
the
think that
academia,
the
we're
doctors
working
that
with academia that
live,
wants to join us and
work there, they need to
together
be trained.
so we can improve the situation.
Personally, I've seen
It's not
when
easy.
we do surveys
We know that
that we
it's gonna
take
take up a lot of
interpreters
time.
and
It's
then
gonna take a
the
lot of
interpreter
effort
asks a question, the other person
because,
replies
but we
a
need to do it.
2, 3, 5 minute
Okay, so
answer.
thank you so much. So
And
I
then when
mentioned
we
the
ask them,
Gastronomy
what did they
Institute
say?
in Mobile and
Oh,
the
she said it's
backpack
fine. That's
and
it.
the backpack
Yeah,
program.
she's
Who is
fine.
financing this effort?
So I think that
We started in
those things need to be
2019.
taken care of
There have
because
been different sources of
we
financing.
want to make sure we have good interpreters and they actually share with us the entire information the patient is sharing with us, even in our own, even in Spanish.
Through
When we speak Spanish,
different projects going on in different countries, we have been able to work
people
with
do not understand very well. For instance, when we ask for samples,
resources,
sometimes
and
it's
we
hard
have
for
been able
them,
to
for us to
sustain
explain
this
ourselves,
team
even
of
though the
this
indigenous person speaks
initiative,
Spanish. So these cultural barriers not only have to do
especially
with language, but
in the
also
mountain
with the
ranges
terms and the
places that
jargon and the
it's
way
hard to
people
reach.
see the world.
But we need to find in the next.
So the fourth question is, how do we work
all
with
these
private
initiatives can
practices
be regular,
that
set up in a regular schedule. So
working
more
with
effective.
TB
But
patients in these native populations?
we're getting international support. But
Right now, there is an all we do is when we do some research and we have identified not only TB but other diseases, we talk to them, to the medical practices. So they don't charge these patients, so they charge a very small amount. Yeah, that's how things have been done, but it's a good question. I think it's a very good criticism that yes, we should
ally is the health department
work
or the Ministry of Health because they give
with
the
them
authorization
so
to the green light
they
to
do
use
more
substances.
for us,
So that
so
was a
for
hard
these
start
people,
for us.
so we can change the vision on how
Because we
to
need to find evidence
actually
of
help
how those programs would
these
operate
people's.
and evidence that how beneficial would be for us. Then we have to fight against the
Thank you for the
stigma.
question.
It's been a big challenge for us. That's why the initiative.
No, thank you,
We don't
doctor.
do TV fairs.
There's another question.
Health fairs, because in that case we can just hide there and
I want to know if you have any information of drug resistance incidents in these native people populations. Not for all of them. We have done some research, and in that research, in the primary cases, about 4%, and in treated cases, 29%. So 1 out of 3 persons with TB in those populations, they have been previously treated.
Sometimes we don't want to treat people that only have traces.
The probabilities of being multi-drug resistant are very high. So it's good that you mentioned this because
they were not familiar with these new techniques. That was a problem.
treating a multi-drug
need to train them,
resistant TB
educate
case
them,
in
and
this
to let them
population
know
is
how
a
to
whole different
diagnose
story.
and
It's
they
more
how to
complicated
treat people, even if they don't have, by following different
because,
diagnosis
as I
methods.
said,
And
people that live in very remote locations,
maybe use
they don't have
so many more
access
years
to healthcare,
in this outreach
and
efforts.
they don't complete their treatment.
Working for people working at
And of
shelters,
course, the costs
they are great
for both
we should let them know
for the patients
consequences
and for the healthcare
crucial
system
for this and for
are very
able to
high.
help us
Should wonder in
improve their
each
situation
one of
because
us in our state, what's the budget at state level?
so yes, I really suggest you read these guidelines by the WHO.
And you will see that these
Thank you,
budgets
doctor,
for TB
for
are
your
very low.
participation.
And
Such an
it could be
interesting
the case that in
presentation.
one or three
Thank you to our
cases,
sponsors, Magno and Nissan.
is that only
We also
in a
thank
couple
the
cases we used up
Valencia to
50% of the resources allocated for TB.
The English presentation. You
So
can find it in the
we need to work on working on other
We also want to thank the
diagnosis methods, better diagnosis methods. We are trying to use nanoparticles in the vacilloscopies and trying to see if we can improve sensibility,
We want to invite you next week.
if we can capture more cases, and in these cases try to see whether actual conditions are, then that would have a very good impact too, because knowing many of these communities, they have a lot of migration. And so these factors make things more complicated, and it's very hard for us to get some good results. Thank you. Next question is, how can we foment the communication between human rights institutions and surveillance programs? We need to be very open. We need to be very open on both ends. In the case of the national TB program, fortunately, in recent times, they have been very open. And not some other sub-administrations within the Ministry of Health are not as open. Yeah, sometimes the paperwork is it's too complicated, and it's hard for us to get the resistance for these populations. And the human rights institutions, they just need to be willing to do it, because they know that it's going to be a complicated program endeavor. And we should also work together with different groups, such as some groups for patients with diabetes, some groups for people living with HIV. We should try to work together. And also some immigrant organizations, like here in Tapachula, we have one. There are many more around the country. And some of these institutes, they don't wanna take part in the tuberculosis efforts, because I think we need to get more incentives for these different organizations, promote more at government level, to promote more projects and for better collaboration among these agencies. Yes, and we have 4 more questions. Let's see if we have enough time. Let's just take one more question so we can wrap up and begin the next presentation. The next question is, do we have any records on the efficacy of contact tracing in these populations? No, we don't have any. No, I don't think there is. There is at an individual level in cases where the person comes to the clinic, but in some cases where there is no resources for follow-up, we don't have that data or evidence. I'm going to talk about in Altamirano, San Carlos Hospital. I think that that's a great hospital, and they don't have enough resources, but for lack of resources, and because since they don't have enough resources, some people have had to stop their treatment because they don't have enough medications for them. Well, thank you so much for your interesting presentation, Dr. Sanchez. Now I want to remind that this event is being sponsored by Backmouth Company with the headquarters in Mexicali and offices in Ensenada and Tijuana, and distribution throughout the country. Also the Nissan Company, which is headquarters in Guadalajara, and distribution nationwide. Now, we want to welcome Dr. Isaías Orozco Andrade. And I'm going to give you a brief introduction. He's a pediatrician trained in infectology and pediatric infectology by the Children's Hospital in Chihuahua. He's been working for 30 years in TB. He's a member of the Mexican Academy of Pediatricians. He's written different papers on TB and medical issues. He's a professor in several medical forums, national and international. He is the chief of the TB diagnosis, a comprehensive treatment of TB by the Border Medical Services in Ciudad Juárez. He's also a member of the National TB Research Network. He is the medical coordinator for the Juntos TB Binational Project in Ciudad Juárez. He's a clinical leader from in the drug-resistant TB program in Chihuahua. His conference is titled TB Medical Practice, Comprehensive and Multidisciplinary Care. I want to remind you, Dr. Orozco, that you have 40 to 45 minutes for your presentation. Thank you so much. Thank you, Doctor. I'm going to share my screen. Okay, please let me know if you can see my screen. Yes, we can. Yes, we can see it. Okay, perfect. Well, thank you for your invitation, Dr. Raquel Muñiz, and all the FoVI-TB group that organized in this international forum. This is the third edition, and it's been great for all TB professionals. Without further ado, I'm gonna begin my presentation. This was originated back in 2010. We presented a project for the Comprehensive Clinic for TB. And as Dr. Lourdes mentioned, here we talk about a regional clinic because we could not just have we cannot have a clinic like this for an entire state, especially for the state where, like Chihuahua, which is the largest state in the country. So times have changed. These are some of the clinics that you all know, some photos, iconic photos of what TB treatment used to be like in Germany, where they would treat them with clean air and healthy food. Yeah, I'm sure many of them got better, but most of them because most of those misdiagnosed and it was not TB, what they suffered from. So we have all the TB laboratory in 1936 in London. This is in Segovia, in Spain in 1943. They're all very similar. And this was the first, this was the first clinic in Huipulco. Now we know we should call them people with TB. We need to call them people living with TB and not. And this was in 1936 when the Huipulco Hospital was opened. In 1969, it was known as the Pulmonary Disease Hospital in Huipulco. In 1975, it became the National Pulmonary Disease Institute. And now it's called the Respiratory Disease, National Respiratory Disease Institute. In 2006, it was named after Ismael Cosío Villegas. Now, briefly, we're going to talk about the numbers. So you will know that every year we have the global TB cases about 10 million, over 10 million. In 2020, only 10.5 million were notified. Out of this 10.5 million, 6 million were notified, and the mortality rate is 6.1 million, 1.5 million. So this is we see that every 3 seconds, one person is infected by TB, and every 21 seconds, a person dies from TB around the world. So we all know that most of the cases are seen in men, especially men and women in working age. And for 2020, 11% of the cases were for people under 15 years of age. So the deaths by tuberculosis, we see that large number of the people who die from TB also suffer from HIV. So obviously COVID-19 around the world came and it'll set us back to our success for diagnosis and treatment of TB in Mexico. Mortality reached numbers that went back to the old numbers that are very high. We had a 5 to 10 year setback for mortality for tuberculosis. So before is talking about today's presentation about a comprehensive care of TB, I wanted to talk about this because last week, Dr. Rafael Ariado presented a presentation for multi-drug resistant TB cases. And this is, I'm going to say, the first justification as to why we should create and we should foster a comprehensive clinic for TB in each state of the country and in many cities of the country. So we see treatment is free, but drugs are very strong. So we need to take them with enough food. Most of us come from poor families and we only eat once a day. Sometimes we cannot take the medications. They don't do it because they suffer from stomach aches. And I love this sentence by the Thailandia healthcare official. This testimonies from a book that was published in 2006. The World Day for TB is like the flash of a camera. It comes and goes right away. So yeah, as Héctor Sánchez just mentioned in the previous presentation, yes, we said we promise support to these populations, but they never come. So people feel discouraged in the populations. And this graph was, when I saw this graph, had a great impact on me because we know the TB Day, and that day so much is promised, but after that, the day after, the next day, nothing happens. Everyone forgets about this and no one delivers. Just remember, for many years, we used to see these posters in clinics. Now we don't even see those posters. Someone who's scoffing, we don't even see those posters we used to see in clinics back in the day. When there's a stigma for people living with TB, especially those living with HIV, and also the aggressive behaviors of the healthcare providers in these clinics. It has been reported many times because a patient with TB is discriminated against even by the healthcare providers, by doctors, nurse practitioners. Regardless of how effective the treatment is, at the end of the day, you just the only place where they can get treatment is at this clinics. But some people rather die than going to those places because they are mistreated, and there's also a stigma with this disease. So they rather stay home and die. So no one knows that they have TB. TB should not be seen just by experts. This has an impact on everyone, and everyone should assume the responsibility. And it's true. Very frequently in the States, most of the healthcare staff, they don't wanna care for TB patients. And there's very few people who are willing to work with this population. At least that's the case in Mexico. Many organizations think that all they have to do is they need to be informed about this, but no. We cannot just go to the clinics and give them information, but just leave without giving them resources for providing the treatment. And most people don't want to deal with TB patients because they don't want to be they don't want to be infected by TB. And during the pandemic, we saw that many TB patients, they didn't go to clinics, so they didn't complete their treatment, and many of them even developed drug resistant TB. We should promote efforts from the government, and the government should feel them as their own. You can see that social pathology, one of the main problems that TB patients is, even those who have been cured, because they have to go back once they're cured to this social pathology, but they have to see we need to see poverty, not only about financial poverty. We're talking about poverty as a pathology from those government entities that they don't have the sensibility, the knowledge, the willingness to participate actively in these TB programs, where they don't have enough resources. We don't have a good resource management or enough resource management for this condition. To reach our goals, we need to get some other members of the society, teachers, drivers from different social strata, and they should all be captured through the different programs. We require a wide army that can help us control this disease. I am convinced that TB treatment is a true service culture for the humanity, because it goes beyond just giving a drug to the patient. Because then a lot of the healthcare providers, when they interview many of them and they ask them to explain more about this, so he said, no, you would understand this. Yes, some of them have very big egos and they don't want to be taught anything. So we have policies coming from the federal government and international community that the patient should get observed treatment. Well, we cannot do this because a nurse visits some households, but some other conditions that need to be addressed, and no one can take that into consideration. And she said, we're only 3 people in this clinic in Ciudad Juárez. The TB program for the city is only 3 people, and that's not enough. So I think the government does not see TB as a threat. And it's more based on their faith than on science. They believe that some countries have some great success for TB, and that's going to have an impact on our cases here. But that doesn't mean that in some rich countries they have been very successful, but that doesn't mean that we're going to have the same success here if we don't work and we don't do our part to make sure that we reach the same level of protection for them. And we should promote investigation in our own countries, so we cannot just have the faith and hope that everything's going to get better just like that. Some people think that some patients have been poisoned. Some people have this belief that the gods have punished patients. So we need to deal with cultural factors, education, and these are very major barriers that keep us from reaching those people and provide them with the right treatment and early treatment. We haven't shared the media all the information about the program because on the pilot stage, just remember in Tijuana, we changed the staff for the TB program, and every 6 years we need to start over and over. So right now we're just moving forward, trying to have a program that is being consolidated, that is being solidified for the coming, because every time we have a stronger program, we need to replace all the people running that program, and then it sets us back. We need to have good connections and access to quality healthcare. And people who get access to these services, they will be successful in the treatment. Yeah, usually people who have enough resources and they have a leverage, they can get the medication and get early diagnosis and timely treatment. So TB affects people, working age people. And as this Brazilian person said, that this arbitrary decision of the president to end this campaign and ignore all the knowledge that has been acknowledged, has been obtained throughout these years. Every administration changes their policies and their people leading these programs. And what happened here in Brazil, the Foundation, who is the public health institution that is an excellence group, that the professionals are high level trained, and they were well paid. What's wrong with paying well our healthcare providers? Actually, that's going to help them have better life, and they will work better and have more willingness to help the population. It would be also great to provide incentives to the population. And lastly, this testimony that I think had a great impact to me. My husband is afraid of me. Actually, my dignity, my honor have been diminished throughout the disease. No one sees me the same way they did in the past. My mother-in-law is finding another woman for my husband, and my husband encourages me to commit suicide. So in this book, you see the story of this woman. The mother-in-law would bring poison for her to commit suicide, so she just get rid of the problem for her son. Fortunately, this woman was cured and she moved on. So this book, you can find these testimonies in this book, and we also have testimonies in our country. This is Ricardo Enrique, and as he says, this is his home. He's Jewish. His father was a rabbi. He was getting trained to become a rabbi 7 months ago. He has 4 sisters and a brother, and then he lived with his parents. And there's a case in June last year. I was diagnosed with TB. I had to leave school. Next year, I'm going to start the 6th grade. My favorite subject is natural sciences. My mom takes care of me. Sometimes my uncles come help us. But the problem is that my dad has a condition. What I have is nothing compared to what my father suffers from. So I would like to become a doctor when I grow old. I was diagnosed with TB a long time ago. I have 3 sons and 2 daughters. My grandkids, they come and visit me, and they bring drawings that I paste on the walls to make them feel better. So this person, 19-year-old, said, I was embarrassed, I was ashamed of having TB, and I stopped going to school. And this other guy said, 6 months that I was about to die, and learned that I could just relax, and I had to go to the doctor, even if I was afraid. When I got there, I was afraid, and the doctor called me because he said, you cannot just abandon treatment. So there are many cases. Some people are abandoned for their family members because when they know that they have TB, their partners leave them. So we see these consequences derived from conditions such as TB. And of course, this is not easy for some people. It's not good. It's not easy to live with a person with TB. So how can we eliminate this? We need to improve the financial, sanitary, environmental conditions for these people. This is one of the best ways to improve TB case situation around the world. This is our problem here in poverty. Poverty is a major barrier. So we need to get rid of those stigmas. This is a patient with TB. He even used, when he completed his treatment, he used this little slips for spelling TB as a celebration. Now, out of 10 patients diagnosed with culture, 2 of them, they had bacilloscopy, positive bacilloscopy. And in our countries, especially the government labs, they do bacilloscopy, and if bacilloscopy is negative, they don't do the culture on the sample. So this, we lose 8 out of 10 patients. When bacilloscopy is negative. What people don't want to talk about this asymptomatic TB. We all know through this study that 41% of patients were diagnosed with TB with a culture where patients with no symptoms. So we updated to last year in 2021, and we saw that this number went up to 50% of these patients were referred as asymptomatic patients. So subclinical asymptomatic TB exists. And so we need to talk about a comprehensive, a regional clinic that will help us treat and help patients. We need to have a good strategy for we should open regional clinics for treating these patients. Okay, I'm going to tell you about this. We should have a comprehensive clinic with a multidisciplinary one with enough staff, with people who take care of rehabilitation, psychologists, lab staff, social workers, obviously doctors, general doctors, epidemiologists, infectologists, pneumologists, so on. So we can have a multidisciplinary treatment for our patients. And of course, getting some benefits for the healthcare providers and the patients. We will need to have staff willing to manage resources and research human and exclusive resources, exclusive dedicated to TB, and also the commitment for the authorities. We want authorities that actually commit to fight and end TB. Also have the collaboration from human rights offices. I'm not saying that we have to pay too much to healthcare providers. No, just some good money for them to live happy with their family. So we said TB is a serious public health issue that needs to be addressed. The goal is to reduce TB cases in the population, to provide treatment always observed, 100% observed for patients in order to heal all the patients and to make sure we avoid drug-resistant TB cases. Because we see that you see the cost for the public health system for patients with regular TB versus a patient with drug-resistant disease, drug-resistant TBs, well, the costs go up in the latter. So we should also be monitoring all the patients. So 100% of our patient population is cured. We want to create a clinic, making sure we have an early diagnosis and treatment for all the affected people and their family members. I've said this before, this hard journey for the patient once they're not diagnosed with TB and the treatment and they complete the treatment. Many patients, they abandon the treatment even before they begin because because the lab results take forever, because there is not enough medical staff, there's not enough drugs. So sometimes they just abandon the treatment since the very beginning before they even start. Now we need to be a training center, continuous center in order to create experts for the management of TB, setting a permanent reintegration patient program and also financial stimulus for the patient that is healed, and those for the medical staff that are responsible for providing the treatment. This is a clinic in Ciudad Victoria. It was created a few years ago. This was the benefit the Rotary Club provided. So this is a very different clinic that it works on diagnosis and treatment of TB, but it does not include all the other factors that I'm suggesting here, proposing here. So As Dr. Sánchez mentioned, native populations, such as the indigenous Tarahumara population in Chihuahua, said that when Spaniards came, they were over 1,000 groups living in this area. Now we only have 4. However, as you can see, the living conditions are so bad, and they make them vulnerable to TB, and not only to TB, but any other infectious disease. And here you can see this girl. All these patients that you see here, they're indigenous patients from native populations. She's Carmen. She has a pot illness. She had surgery in Children's Hospital in Chihuahua. She had a titanium case that was very expensive back then. But children with pot TB and even with TB in the spine, they would just leave the hospital in a wheelchair. But now that we have the possibility of operating on these patients, now we have much better outcomes. And of course, here at the border in Ciudad Juárez, we have immigrants. This population, this Tarahumara population, and they are immigrants. They have some people there, them coming from other countries, from other states of Mexico, and they're a floating population in Ciudad Juárez, and they have their own characteristics. We have Tarahumaras in Ciudad Juárez. We're also trying to get a better life conditions for them and for their families. And they come to Juárez trying to cross the border. So why we need a clinic? Because we want to be able to control treatment that should be directly observed treatment through different strategies, such as directly observed or video observed treatment, and also the possibility of creating mobile units for TB patients, such as these motor vehicles. These are vehicles they save on gas. They are very economic. They are very small vehicles. It's like a motorcycle with a case on top, with a shell on top. So we can bring mobile X-ray machines, and so we can reach different areas of the in our state. We can even take some blood samples, and as I said, X-ray machines, so we can provide the right treatment to patients. These are just examples of how we would like to see the uniforms for our staff. So in all the country, the entire country, even the smallest country, there we see these supermarkets, and we see these drugstores. Going to be very convenient for, especially in these large companies, in those large stores. It would be great if they could have a designated area for a doctor's office, which is a place where we can observe the treatment. And so maybe the government and the TB programs, they should talk to these companies, so maybe give them some financial, some tax incentives if they do this, if they provide this space for directly observed treatment. Yes, that could be a good incentive, giving them some. We could be able to have some treatment units in these grocery stores, and that would be great. It would have a great impact on the status of these patients. So it would also be very convenient having a reference and counter reference centers. So all these different units could see patients coming from all over the country. So they are treated here directly here by well-trained staff, well-qualified staff. We could see this frequently here in Ciudad Juárez. We see that institutions from other government stages and areas that deal with healthcare, they don't have the right information and they don't have the knowledge for providing treatment. And that's a big barrier for us to reach success in these patients. So would be convinced that this clinic would see all these patients from all the different health institutions, and they would come directly to these centers. Also, the long distance medical care. And so let's say if the patient cannot come here, we could through internet that is basically in all the populations, we could give them online treatment or and trying to improve the diagnosis and treatment of TB. So my advice would be to invite the private sector, civil organizations, religious groups, and all the different offices that live in their community leaders. They should come up a council for the management of TB and see Confia TB. Let's all trust in this program. Let's trust in this clinics. So we provide enough resources, not only for diagnosis and treatment, but also stimuli for the patient and their families. As I said, yes, some financial support for healthcare and patients. The productive reintegration for TB patients. Frequently, patients, they are immigrant population that they are unemployed. There are populations that are looking for better opportunities, and their local population that were let go due to TB or many other reasons. But they need to find a job. And sometimes these people they are undertrained. Then we should give them the chance so we could have here trainers and in arts and maybe somebody can woodwork and electricity, bakery. So when the patient completes their treatment through this program, they would get enough money to open their own business. And maybe for 2 or 3 years, they were followed by social workers. So to make sure that these resources are used for this business, it could become a family business. So we're not only going to reintegrate a cured patient, but also an individual that is productive for the society and their community. And this will improve their stay in these clinics for this kind of patients. So this could also be used for sport events, cultural events, having students from the physical education schools and fine art schools. They can come and help these patients. So the staff from other areas teach them how to do keychains or belts or something, and we can have annual fairs so they can sell their products, all those products that they learn and how to make in these clinics. So this is not just about making sure that the patient is taking the medication, but it's to also give them all this emotional, financial, educational support. Also, a continuous TB education program, because we need to create experts in the community to provide support to these groups to support their peers, so we can eliminate these stigmas and discrimination, so that the new patients will understand that people went through the same thing and they are cured despite all the obstacles. So the difference between what we do and what we can do, if we close that gap, we'll be able to overcome many healthcare problems. Dr. Benito Cobb decided to do the same. So we need to take our responsibility. We need to do our work. The politicians and doctors, they need to do something. They just not pretend to do something. No, they need to actually work. Just listen to what the community has to say. No, they have to work hands-on these situations. So I tell the politicians and governors, remember many of the biomedical and human resources that have been able to have helped you to recover your health. You can do much with little resources, but with great willingness. So we can imagine a TB world, a TB-free world. Yes, we can totally imagine that. I'm sure we can do that. We have different experts in our clinic. We have medical doctors, radiologists, a very large lab. It's a lab that is certified by the CDC in the US. So we have all the production agencies, UV filters, we have air filters, and since the COVID-19 pandemic, we installed in the air conditioning system, so air filtering systems to eliminate the germs that could spread diseases among patients and the healthcare providers working there. So it's important to mention that this center does medical exams for people who are moving legally to the US. So we have a foundation that provides support, free support, accommodation, food, medical attention for TB, so they can be successful. We offer through this foundation is CATRE Foundation. These are the facilities. These are facilities, a little small hotel where each patient has its own room. We have a dining area. We have a living area. We have a small gym with a treadmill, a static bike. As you can see here, this is a basketball field. So we have another area also where they have some other rooms. So all this is provided free of cost, but patients with TB, but I said it's only for patients, immigrant patients that come here to our office, they are diagnosed with TB. So I also personally, I work in the Juntos of a national program for TB. This is a national program. The state of Texas provides financial support to be able to diagnose TB through molecular tests, X-rays. And as I said, I am the medical coordinator for the Ciudad Juárez, and we have 3 nurses, and they do an amazing work. So just to give you an example, last week, Dr. Aliado said, at least we need to study a group of possible contacts and do the contact tracing. So a month ago, we had a HIV patient. The Ministry of Health asked us for support for the monitoring their treatment and their analysis and sex one. All these kids did all the diagnosis. We referred a couple, 3 patients. When they start working on their contact tracing, they identify 30 contacts between their friends, family members, and staff and co-workers for these patients. So it was not just a single patient that we have to work with. We have to do very hard work to the IGRAS and all the contacts, the 30 contacts that identified. One of them was his partner was also diagnosed with TB, and the rest of the 29 contacts, they are being studied out of, we identify infectious or latent TB, 5 of those people, and they are receiving treatment already. So now we have the advantage of being able to see patients with some binational status. So we combine these 2 entities. Patients that were deported from the US, and we see those patients here. and we get very good support and provide very good support. We have been criticized in this program, being saying that they will make things work more complicated for the government agencies. I can tell you that right now we have on the treatment 18 patients with active TB. They are being treated. In addition to that, we are studying about 80 contacts. We are doing all the contact tracing to be able to diagnose these potential patients. So most of the patients are addressed by BDOT. I said video direct observed treatment in a conference call. So, however, we have patients with a condition, particular conditions of children. So I have a kid with meningitis and TB when they need to be closely monitored. So we cannot beat out all the patients. Some of them we will have to go there in person and see their household, they see the environment where they live in, and so we can provide better support. We have also been lucky enough to have support from to get some meals for patients. Sometimes we give them some financial resources for transportation. For commuting, so they can go and see a doctor on their monthly appointments. It says 4 of us, we get together and say, okay, let's collect some money to provide this, to give to this family that needs it. You know, Ciudad Juárez is a family, a very insecure family city. So many of the patients that we see, they live in dangerous areas such as Las Tecas, Tanatra districts that we know that they're very dangerous. We have to be very careful. Fortunately, our patient are very brave, and we have been able to have 100% success rate. The same happens to Servicios Médicos de la Frontera. In the last years, we have this diagnosis and treatment unit. Of course, there are some characteristics, especially in the Juntos project, people who are not migrating. Some people, they just abandon their treatment. Unlike the Servicios Médicos de la Frontera, these patients, they are motivated because they will get a visa for moving to the US. So this would be all on my end. As the Bible says, Jehovah will give what he will give to those who support the poor, and he will be repaid in the future. So yes, do you have any questions, Dr. Lourdes? I'm here. Thank you so much, Dr. Orozco. Your conference was very interesting. Okay, now we're going to go open the Q&A session, and the first question for Dr. Orozco is how do they do psychological and social support for the population, for the healthcare providers to avoid discrimination? Yes, as Dr. Sánchez mentioned, yes, we need to work, we need to educate our healthcare staff. Yes, because the Juntos staff, these are nurses that they are so involved in the diagnosis and treatment of these patients that they go visit their households and they see how they live, that their emotional indexes, their emotional involvement has an impact on their health. Because I'm going to give an example. It was on Sunday at 10 p.m., one of the nurses said, Dr. Orozco, what do I do? This patient was detained because he was drinking on the street and he was using drugs, and the police, he was arrested by the police, and then, but he needs a medical note from us. So doctor, we need to go and see the doctor, this patient because he was hospitalized and he's a HIV patient and said he's not gonna be operated on, but right now because there's a COVID pandemic right now he cannot be operated. So I can tell you, I don't know if in other states of the country, but the healthcare staff for this I don't know about other states, but here in the case, our staff, they don't get a prior emotional evaluation. No. But permanently and regularly, they don't get any emotional support. We see the burnout in our healthcare providers, but even today, we have phone groups, hotlines for patients, but our healthcare staff, they are not being taken care of. I've had meetings with the nursing staff from Juntos, and they are falling asleep. They start snoozing because they are tired because they went out in the field taking samples and they don't get any emotional support. So the Juntos group, we depend on a civil organization that provide financial support for paying the salary of these nurses, but the government area, they get some money, but not enough. And there is no office that help them with this. When I was a director of the Children's Hospital in Chihuahua, we did some research study about the different factors that affect the emotional well-being of our coworkers, and we came up with a support group. So we would give them, in addition to psychological counseling, we would give them some exercise, some time to exercise. I said I was removed as a director by the new administration, and then much of the staff that I was working with us on this, they just were gone too. So there's no follow-up on those efforts. But we definitely need to take all this into consideration because this has a great impact on our healthcare providers. So we could say that the staff is exposed to, for instance, to suffer from burnout. But in addition to that, there is no contention group to try to minimize these effects, right? No, that's why as part of this comprehensive clinic, in one of the slides, I mentioned that for the protection, that we need to protect the medical staff and their family because this is a whole chain, because it's not only affect the personal staff working directly with the patient, but they go home and they have this emotional burden. It's going to have an impact on their families. So it's very important for the nutrition and psychological departments. They will have to see not only the patient, but also have to see the medical staff, and they will promote social, financial, and cultural and physical activities so we can help them. Because sometimes medical staff, we forget about ourselves. So we forget that we can go out and eat in a picnic and at a park and breathe fresh air and relax, because we are working too hard. My first 3 children, they said, okay, Dad, I understand you, because one of them is a doctor now, but back in the day, I missed so much from my children's childhood, because I was working so hard. We keep trying to do our best to have an impact, to make a difference for these patients. Thank you. The next question is, how is it possible to promote? How can we make the government see this and actually embrace these programs and don't see this as something that is just there, that does not require their full commitment? Yes, we see when I was a director of the Children's Hospital, I had to go to the public hearings and present this program because as a director, I didn't have I couldn't see the governor to discuss this. I had to find different ways and visit different forums to present this project. I managed to get this project passed, but it was just, but then it was just thrown to the trash. But that governor was now in jail because he stole so many resources. Because I was told, doctor, we have 9 million pesos available. We could use this money for this clinic that you want to do. And then the same doctor said, guess what? We just lost this 9 million pesos because we have electoral terms are coming. So we lost that money. So very sadly, I can say that we will have to foster these values and promote these values in our children. So when they grow up, we need to think ahead. We need to think ahead because people, public officials, and they have very bad habits that we won't be able to change. The only way I think that we can have a good future to be able to create the sensibility among the people will be through our children. We need to teach them values, so when they grow up, they make a difference. Unfortunately, we see on the social media. In the social media, there is very misleading information because people pay more attention to the negative and they don't pay attention to all the positives that we're doing here. And then we do all the hard work that is being done. Our juntos staff, we go visit the households of these affected families, and they see the actual problems that they see. They don't do it from their office. They actually go. Thank you. The next question is, how routine microbiological culture is being used in the healthcare system in Mexico. Fortunately, things are getting better. We have better rapid molecular testing. Most of the states don't have it. States in the southern area of our country, they have less resources for this. But yes, it's true. In the past, and the national program was not very open to this. So we all experienced those difficulties, those barriers. It was very hard for us to open a forum like this to be able to talk about the difficulties and the scarcity we had in the different states. I mentioned that 20 years ago, we had the participation of a director of the national program, and he would ask us, okay, how could you not find TB if you're looking for it all the time? Yes, of course, we need to actively look for TB. We need to actually try to find it. Of course, we're going to find TB cases. We cannot just ignore it. In the past, we had to send our samples to the federal labs, and some of the samples were lost, and they would take 3 to 6 months to get the results. And of course, a patient would abandon treatment before beginning, or they would die, or they would simply just, we had to start treatment without hard data. So yes, we still have a lot to be done, but we're working all very hard. Marta Angelica, we're all working very hard. We already have pediatric drugs. We don't have enough. We are not getting them timely, but it's coming, and so it's good. That's good enough for now. So about the Mexican TB program, is there any money allocated to the social reintegration and working reintegration of the patients? No, in Tijuana, we don't have any of that. The budgets we have for diagnosing and treating TB are very small. They are very insufficient. So I can tell you that in this case of Chihuahua, that The budget, the annual budget was 350,000 pesos per year. That's not even for enough for gas. So let alone medication. And of course, the budget is very low. It's not enough. We cannot pay for the drugs, and we can, that money is not enough for a project that one like the one I'm talking about today. I guess this is the same at national level, right? It must be the same in all different states, in not only for Chihuahua. Yes, unfortunately, I'm sure. The next question is, the foundation supports this comprehensive clinic. Is a national or international foundation? No, the foundation that we get support from is a local organization, is part of the clinic itself. When we had the Diagnosis and Treatment Center for TB, this center was created on demand by the CDC in the US. We're the only clinic at a national level to treat patients with a migration, in a migration process to the US. So the US CDC said, okay, medical services, you need to manage this. There is 3 clinics that do clinical checkups. One in dos in Ciudad Juárez, 2 in Ciudad Juárez, and 1 in Mexico City. For the patients diagnosed with TB, they need to come here with us to the Diagnosis and Treatment Center. But also, Médicos de la Frontera, we are the only ones that offer this plus to our Servicios Médicos de la Frontera patients. So we provide them with all the care for TB. We have had some patients that we had to invest 3 million pesos on a single patient with a multi-drug resistant TB case. He was from Mexicali. He came here, he got tested, and we identified this situation. Had to be hospitalized because, and the investment for the single patient was 3 million pesos. So everything has to do with TB. This CDITTB Foundation provides all this for free. So accommodation, food, and the treatment. If the patient has a comorbidity, and then of course the patient will have to pay for the treatment for diabetes and so many others. So the clinical expenses are supported by the foundation, directly by the foundation. No, actually the clinic supports the foundation because the clinic will charges for medical checkup. So they have to pay for same medical checkup, which is a requirement for their immigration process. So the clinic provides some money to this foundation. The foundation allocates some resources, and they give us the facilities, also pay for transportation because we're not next door. So every day, a van after comes from the clinic, takes up all the patients from the facilities, and they take them to the clinic. We observe the treatment, and they are taken back to their rooms. So, doctor, do you know if these work centers support patients with their treatment? A large number of these patients are let go, are fired when the employer finds out that they have TB. Now, with this new regulation that protects workers, employees, this gave us some advantages for the employees, because some companies, at least here, they think twice before firing a patient. I think these measures are helping, but according to this Mexican official standard has been discussed for 6 or 7 years. But now, since when the pandemic, the things started to take up speed, so momentum. So require so much support. You not only need the paper, we need to be enforced. Okay, we're about to end. Thank you, doctor, for your participation. No, thank you, Dr. Lourdes, and all the REMI-TB team. Thank you to all the sponsors. Dr. Raquel Muñiz, thank you so much. And as I said before, I'm like Vicente Fernandez. If you keep applauding, I'll keep working. So yes, we need to work in the benefit of humanity. Thank you so much. We want to thank our sponsors, Pacman Vision. We want to thank the interpreter, Claudio Valencia, who was interpreting both presentations from Spanish into English. The English conference, you can find it in YouTube channel, REMI-TB. And likewise, we want to thank for the support provided for the broadcast of our event on YouTube, Facebook, and the official channels. Thank you, everyone, each one of you, and we hope you can join us next Tuesday, October 25 at 9 a.m. Pacific time, 11 a.m. Central time. In next session, we will have Dr. Ana Marcia del Saubin Imaras, who is a researcher for the biomedical research on the Sao Paulo, Brazil. And she will be talking about TB control in the context of One Health. Likewise, we have Dr. Paula Fujiwara, who's a chair for the World Program to End TB by 2030, 2050. They'll be talking about zoonotic TB. The evaluation for session 1, 2, and 3 is open. That will be continue open for the next week. About a self-assessment for session 3 will be available later today. All the evaluations you can be found on www.remitv.org. So please follow us on our social media, REMI-TB, Divulgare, UBC, and Facebook, REMI-TB. Have a wonderful day.